Today we're talking about sacroiliac joint movements, and I'm going to be using anatomical terminology rather than osteopathic because it's the only way we can actually talk biomechanics here, that actually looks anything like the biomechanics we talked to about earlier joints. So that's what this is. It's reasonably short, it's quite simple, but a lot of it is counterintuitive. So just be careful with it. It's easy to make a mistake because you're thinking a different way. Good luck. Okay, before we get into the SI joint, let's get some terminology defined because, as I said earlier, this starts to get a little bit counterintuitive. And as an example of that, for the most part, you know what flexion and extension is. But there are some complications. One of them being that dorsiflexion of the ankle is actually flexion of the ankle and not extension, regardless of the fact that the dorsiflexive muscles are called extensors. The best way I think of flexion and extension is that flexion is a movement towards the fetal position and extension is a movement away from it, and that applies to pretty much all movements in the body. I can't think of one where it doesn't. So if in the fetus, the entire spine is flexed. There's no lordosis there. Everything is flexed. Shoulders are flexed, elbows are flexed, wrists are flexed. Hip is flexed, knee is flexed, and the ankle is dorsiflexed, which is flexed. So flexion is movement towards the fetal position and extension is movement away from the fetal position. Now the other thing is about referencing where the movements are. In the spine, by convention, the superior bone is the reference bone. So if the superior bone flexes, the segment flexes. If it extends, the segment extends. If the inferior bone flexes or extends under the superior bone, it's the opposite. So if L4 flexes underneath L3, extends underneath L3, then L3-4 is flexing. If L4 flexes under L3, then L3-4 is extending. And the same thing applies to the periphery. But now the distal bone is the reference bone. So if I want to flex the hip, I can do it by either bending the femur up towards my chest, which will flex the hip, or I can stand with my feet on the ground, bend forwards so the innominate moves down on towards the femur, and that will flex the hip. Now, in this case though, when I flex using the femur is flexing. When I flex the hip via the innominate is extending. It's moving away from the fetal position. So I think if you can manage to hang on to those things, away and towards the fetal position being extension and flexion respectively, and the distal bone in the femur, in the periphery, giving you the reference point, and the superior vertebra in the spine giving you the reference point, you'll be able to grab it eventually. But it does get a little bit confusing, a bit counterintuitive when we get to the innominate, just because of the way we think of these movements occurring, and we're thinking wrong, basically. Quick word about the anatomy of the SI joint and how it allows movement to occur there. First off, this is often described as the sacrum being wedged between the innominates, and that's actually not true. If we was to take all the ligaments out and put weight through the innominates and the sacrum, so pushing the innominates up, which ground reaction force does, and push the sacrum down, which is what gravity does, then the sacrum would fall out of the innominate. It's not wedged in there at all. It's perfectly capable of falling forward. The only thing that's stopping it doing that are the ligaments, really. So first off, that idea is not true at all. And that will come to us later on when we actually look at rotational movements of the sacrum, which has been said they can't happen because it is wedged in there. Nothing could be further from the truth. There's an anatomical oddity about this joint, in that these are not two hyaline surfaces. One surface, the innominate, is actually fibrocartilage, while the sacrum is hyaline cartilage. So we haven't got hyaline on hyaline, we've got hyaline on fibrocartilage. And for one of the purposes of this is to stabilize it. Now, there are lots of other ways of this joint being stabilized, and it needs to be. The amount of force going through this when you're standing, jumping, running, walking, or doing anything else is immense. Massive shearing forces going up and down, and torque forces being generated by the way these shearing forces are not central. So you've got massive ligaments holding this joint together, massive ligaments, the strongest ligaments in the body by a good way. You've got the shape of the lumbar spine. There's a whole bunch of stuff that holds this together. So, and this is where stability comes in now. With that degree of stability, you wouldn't be able to move this. It would be essentially jammed in there by the ligaments. It just couldn't move. But by having these two surfaces interlocking, then that gives it stability. So we have stability also afforded by primary, secondary and tertiary contours of this joint. The primary contour is a V-shaped thing, so we have it facing this way and it's V-shaped, which means that two surfaces really can't glide on each other, they jam up. It's like trying to drive a train down two non-parallel rails. It's not going to go very far. Then you have big irregularities in this joint. There's a central furrow and a central ridge on one side and on the other side. So this furrow and ridge system interlocks. Not perfect, but it interlocks. And then on top of that, you've got horizontal ridges, much smaller as the tertiary contours, and they tend to interlock. So you've got intrinsic stability in this joint by the shape of the surfaces, massive ligaments holding it all together. So the only way this joint can move actually is by the deformation of the fibrocartilage. So if you squeeze these two surfaces together, which is what you do in weight bearing, squeeze them together and then put body weight through this, then these things will squeeze each other, they'll turn and the cartilage will be deformed. The less weight you have going through it, the less deformation you'll get. And this works well because this joint has to be capable of moving around almost an infinite number of axes. And the shape of these surfaces wouldn't allow that unless there was deformity there. So it's a very individual type of joint, this. And while it doesn't move a whole lot, it does move. And this joint, contrary to what people will tell you, does not fuse in later life. Unless it's diseased. Now, if it's diseased, you get bony fusion. Otherwise, you don't. With extreme age, you get a thing called synostosis, where you get fibers of cartilage, fibrous tissue running between the joint surfaces, and it does that. And at the same time, these furrows and ridges get deeper and more pronounced, and the articular cartilage gets thinner. So while the thinning cartilage basically tends to destabilize the joints, these increased ridges and furrows and the synostotic material stabilize it again. So it actually loses range, loses mobility as you get older, but it never ever fuses unless it's diseased. The sacrum is a vertebra. Actually, it's multiple vertebrae fused together. And the convention of its movement is spinal. So when the sacrum moves, it moves under L5. So for example, if it flexes, that is, it rotates in the anterior position, then it will extend the spine. If it basically extends, then it will flex L5S1. And this is what happens with lordosis, kyphosis. So when we're talking about the bone, though, flexion is flexion and extension is extension. It's got no relationship to any segment at all, just itself. So you can see the two movements here, flexion and extension, and they occur obviously around an axis that runs somewhere into the sacroiliac joint itself and across and out to the other side, the so-called transverse axis of the osteopaths. Now, this language is the same as the osteopaths use, flexion and extension. Really straightforward, just think of it as another bone in the vertebra, in the spine. The innomina, on the other hand, is a peripheral bone. And the innomina evolved from the fish's puboischium. and the ilium actually was a projection from the ilium when animals start to go on land that projects upwards towards one or two vertebrae that are fused together to form the sacrum. And it's that projection up that's the ilium, and it's that basically articulates with the vertebra. So this would have the same convention as any peripheral bone does. Now, the problem you've got here is that the innomina and the sacrum are side by side. So we can't even say the superior one has the convention, the inferior one does. They're side by side. So it produces a bit of an issue as to the movements of the sacroiliac joint, maybe, but in fact it doesn't, and I'll explain why later on. So now, as I say, this one's a little bit more difficult to grab a hold of. Anterior rotation of the innomina is extension. It moves away from the fetal position and it flexes the hip. That's extension. And posterior rotation is flexion. And the osteopathic term for that was posterior rotation. Very descriptive, but they're not much used to us when we're talking biomechanics. So just get your head around this, all right? And it will keep on getting wrong, and you'll have to keep getting it right. And I still say the wrong thing sometimes as well. It's just counterintuitive. So anterior rotation is extension, posterior rotation is flexion. Okay, so let's look at the left-hand diagram. What you can see here is the blue arrow is the innominate movement and the red arrow is the sacral movement. So extension of the innominate is anterior rotation. Flexion of the innominate is posterior rotation. Now you can see they're opposite movements. So innominate extends, and in this diagram the sacrum extends. So whether we're talking about the sacrum or the innominate, extension is extension. So we don't have to worry about the fact that these two bones are side by side, because they're moving in opposite directions. It gives you the movement. If I anteriorly rotate the innominate, it's exactly the same as if I posteriorly rotate the sacrum, and anterior rotation of the innominate is extension, and posterior rotation of the sacrum is extension. So that movement is extension of the sacroiliac joint. If you look on the other picture, they're both moving in the same direction, and this is what would happen if you were anterior tilting your pelvis to produce lordosis through the spine. So they're both moving in the same direction. There's no real movement between either of them. Probably not quite true. Probably one does move a little bit more than the other under normal circumstances, but we can ignore that. So movements of the both, if they're both rotating in the same direction, sacroiliac joint isn't moving. If they're both rotating in opposite directions, the SI joint is moving, and it's moving in the directions that you would describe for the bones. Okay? Okay, so rotation. As I said earlier, there's an idea that the sacrum can't rotate. It has to tilt on an oblique axis, and while it does tilt, it's actually an axis that's not going through the sacrum, I don't think. The sacrum can rotate. It can rotate around a relatively vertical axis, and just how vertical that axis is depends on whether you're doing this in lordosis or kyphosis or neutral, but the axis for the sacral movement is actually through the sacrum itself, in my opinion. And you can feel this. If you palpate all four corners of the sacrum and you twist to the right, do it in sitting, twist to the right, you'll feel the left ones go forward and the two right ones come back. Now, the reason this can happen is because the innominates get out of the way. So as I rotate to the right, the left innominate extends, that is, it anteriorly rotates, and the right innominate posteriorly rotates or flexes. So these things twist, the whole pelvis twists, and you can also see that twisting must occur at the pubis as well. So the axis for the composite movement of the pelvis has to be inside the pelvic bowl. Now this may be, the axis may be tipped forward or backward depending on whether you're lordotic, neutral or kyphotic, but nonetheless the axis is spinning around its own axis essentially. So I have no problems with this movement. It does occur, and I'm fine with it. I think the osteopathic idea that this is actually a rotation around an oblique axis only occurs when there is a dysfunction present, and we'll look at that right now. Okay, I'm hoping these pictures are somewhat clear. It's difficult to get exactly what I want from the sacrum. But on the left, what we're looking at is asymmetrical movement of the sacrum. So if I try to extend the sacrum and the left side moves less than the right side, then the left side is going to move further than the left side. Now, this is exactly analogous to the facet joint in the lumbar spine or the neck or anywhere else. So if one side is moving more than the other, that happens. And it also tends to rotate around that abnormal axis. And the sacrum does exactly the same. So I would consider as the sacrum as L6 and the innominate as L7, and try to think of it in those terms. So if I've got hypomobility on the left SI joint and I require extension to occur, then the right SI will move down, the left one won't move at all, and you'll get this tipping and rotating. So it will tip down to the right and rotate to the left. This is what the osteopaths would have called a left on right problem. So let me just make sure I've got that right. So that's happening. So it's rotating left around an axis through the right. And I think that hypomobile joint produces that oblique axis that the osteopaths talk about it. But I don't see it as being a normal axis, but an abnormal axis. On the other side, what you're seeing is the right joint is moving into flexion more than the left. So if we model this, we can say that the left joint is hypomobile, right is moving up. So again, it will tilt to the left and rotate to the right this time. So it'll do that. And that is what they would call a left on left. But I see these, as I say, as pathological problems. Having said this, it should be known that if you actually go in and palpate position on almost everybody that doesn't have a problem with the innominates, with the sacroiliac joint, you're going to find a pattern of asymmetry that is pretty much universal. That is that you're going to find that the right innominate is more anterior than the left. That is, right innominate is extended more than the left is, and the sacrum is rotated to the left as a left on left, if you like, but it's going to be flexed more on the left. It's going to be looking like that, this picture on the right. So that's a fairly universal pattern. It means nothing at all, and it confounds position testing. And we'll talk about actually testing for dysfunction on another video. These are the very basics of movement, both dysfunctional and normal. Understand that the SI joint can be moved from the innominate or from the sacrum, and more commonly from both. One's doing extension, the other one's doing extension. Walking, for example, is an example. Is that happening? So it's a very complicated joint, at least if you were to actually track all of this movement, because it can move around multiple axes very quickly, just change axes in a blink. So just understand these basics and it will make the classroom description and the practical use of this much easier for you. Just spend some time going over this until you're reasonably confident that while it may not come to you automatically, it will come to you a little bit later than maybe your first intuition is. Take care, everybody. Bye-bye.